Dr. Amit Sawan is an extremely talented person. He is working as a pediatric intensivity at Komal Hospital since 9 years. He done his pediatric intensive care fellowship in Apple Saraswati Hospital. It's over to you, Dr. Amit Sawan.
Good afternoon, everyone. Am I audible?
Yeah.
It's lunchtime, I know, but this is the most important topic as the cases are rising. And I'm very glad to introduce Dr. Sumant Patil. As after last lecture, Dr. Sumant Patil need no introduction. So I will directly give the screen to the Dr. Sumant Patil. Thank you.
Thank you, Amit. Let's start with the presentation. Okay, now here we come with the most intriguing and interesting topic, PIMS TR or MIS-C. What do we understand and what exactly it means and how do you manage that? So basically, what happened and how did it come to know? Around April time, end of April, there were, when people were dealing with COVID everywhere, and there was a general understanding, okay, pediatric COVID is not significant, there are no pediatric patients. Suddenly, there was a big cluster of 8 to 10 patients in Evelina London Children's Hospital. And they came with some unusual presentation. They came with circulatory shock, and they were quite hyperinflammatory state, and they appeared to be in some shock syndrome, shock-like state, like toxic shock or possibility of Kawasaki disease. And they thought that this is a different cluster, and these turn out to be later on positive with some COVID antibodies. And similarly, just few days before that, there was a case already reported in US on 7th April with the similar sort of situation. Followed by that, there was so many cases that the Royal College has to take it as an important announcement, and the world started noticing the cases rising all across. So actually on 1st May, Royal College has already put up a guidance on clinical management of these patients, and they termed it as PIMS TR, and then subsequently CDC issued a health advisory. So what is the PIMS or MIS? Are they same or are they different? Actually, they are the same names of this similar syndrome or similar clinical stage. Just that in United Kingdom, they are labeled as pediatric inflammatory multisystem syndrome temporarily associated with COVID-19 infection. That's PIMS TR. So Royal College and Europe so mainly calls it as PIMS TR, while CDC, WHO, and US and rest of the world calls it as MIS-C. So multi-system inflammatory syndrome in children, so which is actually same, but just the different names are different situation. So we shouldn't get confused about it. What we talk about this is the same. So let us go. So what happened? So basically, what are we looking at is the official advisory, health advisory from CDC on May 14th. That what is multi-inflammatory syndrome in children? They gave a proper case definition. So they said it's observed in individuals who are less than 21 years old. They present with fever, laboratory evidence of inflammations, and they require hospitalization with more than 2 organs involvement, like cardiac, renal, respiratory, hematological, gastrointestinal, dermatological, neurological. Any of these 2 organs involvement, along with fever. And no alternative, very important, no alternative plausible diagnosis. So you must rule out everything else. And then they should be, or they can be positive for either current or the recent infection or the previous exposure. So any of those should be fine. So either they should be positive for current or recent SARS-CoV like antibodies, like serology or antigen test, or there is a history of COVID-19 exposure within 4 weeks prior to onset of symptoms. This is what actually CDC said on MIS-C. Now Royal College comes and says the similar sort of thing in a different way. The child presenting with fever, inflammation, neutropenia, elevated CRP, lymphopenia, evidence of single or multi-organ dysfunction, shock, cardiac, respiratory, renal, gastrointestinal, and neurological disorder with additional features which may look or fulfill the full or partial criteria for Kawasaki disease. Very important. I mean, both of them had the similar sort of situation. But importantly, the exclusion of other microbial cause, including bacterial sepsis or staphylococcal or streptococcal shock syndrome, should be ruled out. And any other virus or viral infection who could cause a generalized systemic illness with myocarditis should be ruled out. But you can consider this as a PIMS, and they may be serology positive or they may be PCR positive. So they could be either PCR testing could be positive or negative. So there's not a prerequisite for that. So what is it and how much we know about it? Now, after that, there were a lot of cases they were reported across the globe. So first in UK, US, then all other countries started noticing it, Kawasaki-like symptoms in children with COVID-19 infection. So Spain, Italy, Canada, Portugal, everybody else started noticing in Germany, South Africa, except China. China hasn't reported any yet, although apparently there are some cases. Now in July, India we had our first case in Chennai actually, and followed by a few cases in Mumbai. And there was a big cluster in Mumbai, 12 children with the similar MIS-C or PIMS TR. So now what we see is it is all across the globe. Everybody knows that this phenomenon occurs, and actually now it has caused a significant concern in pediatricians because there are more and more sicker patients coming through with COVID-19 post-infection and PIMS-like pictures. So they are needing more PICU support and even tests. And in fact, there are papers coming out with PIMS patients requiring PICU care. So what is the current understanding and the incidence? The estimated incidence of lab-confirmed SARS-CoV infection in individuals less than 21-year-old was 322 per 100,000, and MIS-C was 2 per 100,000. And this was in New York. This is a New York State NEJM in June 2020. Now, predominantly seen in previously healthy older children and adolescents, important. Obesity and asthma, biggest commonest comorbidity. And they are more severe under 1 year of age and those with underlying health comorbidities, as you see COVID-19 infection. So there is some difference between these two. So clear-cut COVID-19 infections are more under 1 and children with underlying health comorbidities, while these are more with healthy older and adolescent children with obesity and asthma as a comorbidity. Ethnicity, again, more predominantly seen in Black, Hispanic patients, few white patients, and then Asians. So you can see the Asian population is less here, and they have most of these case series are documented. There is obviously a lag of 3 to 4 weeks between the time of exposure to COVID and the presentation of the symptoms. So acute infection. So usually looks like it is like it's a patient who is developing a delayed immune response to actual exposure to infectious agent. So post-infectious phenomenon is what everybody is talking about. Although it is not clearly understood, it probably has got some understanding of immune dysregulation. What do you mean? Is some patients are reacting in a hyper way or hyper-reactive or exaggerated way in exposing, after exposure to the COVID infection. So this is exaggerated and abnormal immune response to COVID-19 infection, which triggers a Kawasaki disease-like hyperinflammatory clinical response, macrophage activation, and cytokine release response, which leads to shock. I don't know how many times you have seen, but before COVID came around, we used to see Kawasaki being presented with dengue-like illness, sometimes even with normal E. coli infection or streptococcal infections. They were triggering Kawasaki disease. So basically the underlying pathology with this illness looks like an abnormal immune regulation, and that is after exposure to certain infection. Now this time it is COVID. So COVID has also jumped into the group of patients or group of trigger factors for this Kawasaki-like disease. And majority of these children are actually COVID PCR negative, but they do have positive serology, so probably a delayed response. This implicates immune-mediated response rather than actually direct virus invasion injury. Very important, because here that's why the role of antiviral probably is doubtful here in these cases. Now 60% of these patients have positive serology with negative PCR. 34% were positive on both tests, and 5% were negative on both tests. So again, despite being negative, there could be a history of exposure to, being exposed to somebody with COVID positive clinical state, and then this also could trigger. So this needs to be kept in mind, and so this means that there is a variable post immune. If you if you look at this, this is very clear-cut picture now. So stage 1 is early infection, SARS-CoV infection, asymptomatic, mildly symptomatic. The child gets into a nasopharyngeal colonization, develops some nice minimal infection, and there is no pulmonary involvement here. This is, and gradually this starts moving ahead with this macrophage activation. Then there is a B cells and T cells, plasma cells get involved, they develop antibodies. And these antibodies and tumor necrosis factor, they actually probably will be developing the hyperimmune response contributed with cytokine release storm. And then this stimulation of neutrophil monocytes leads to hyperimmune response, which actually can be seen involving many other systems, such as you get kidneys involvement, there is pericholestatic edema, skin changes, rashes, then you get ventricular dysfunction, pulmonary edema, consolidation, meningeal irritation. A lot of them come with irritability, which behaves like a neurological disorder. And at the same time, these mesenteric adenitis, so acute abdominal pain, colitis, ascites, these things are present. So likely that there is more of an immune mediated response rather than virus causing any problem. So virus has actually caused problem here, but you don't see anything around here. What you see here, at probably after some time, that you get to see the involvement of many other systems. Now, viral factors, of course, do not explain why some children develop multisystem inflammation following SARS while others don't. And actually, people have looked into it, that some children who were viral COVID positive and did not develop into COVID, and did not develop into PIMS, and some children who were COVID positive, the similar background, and developed this PIMS-like illness, there was no difference between the viral sequences or genomic status of these two patients. So actually, there is no chance to say that the virus was different and it acted differently. It is not the virus which does this. It is actually the post-immune response. So abnormal inflammatory response. Now, myocardial injury mechanism still quite unclear, but some people have found out on autopsies that there is inflammatory cell infiltration into the myocardium, which may be part of systemic inflammation. There could be acute viral myocarditis. This myocardial hypoxia could be the cause of this dysfunction. There could be stress cardiomyopathy, and there could be possibility of ischemia, which can be caused by coronary artery involvement. Very, very important thing to remember. So myocardial injury remains there, but again, the mechanisms are quite different and various. How do they present? Let us see. I got this data from the recent publication, which talks about collective data from systemic review from various papers that have talked about PIMS in Europe. So they have found out that there is persistent fever. 100% patient had prolonged fever. GI symptoms were predominant. 60 to 100% were predominantly abdominal symptoms. Rashes were next. Conjunctivitis, sports, so mucous membrane involvement, neurocognitive symptoms, headache, lethargy, confusion. You can see this is moving towards Kawasaki-like disease. Then at the end, they did have some of them having respiratory symptoms like tachypnea, labor breathing. Probably these are late stage there. And then sore throat, myalgia, swollen hands and feet. What cases that we have these situations? And lymphadenopathy was the least. Now, what did we find them? They come with shock. Top of the list is shock, around 76%. And complete Kawasaki disease criteria, 64%. Myocardial dysfunction is very prominent. Most of them with shock have LV dysfunction on echo, and they have raised trop and BNP. So these are important. Some of them do have arrhythmias. Then acute respiratory failure, which needs NIV or invasive ventilation. Renal involvement, mild to moderate, around 52%. Serositis, lots of ascites, pericardial effusion, some pleural effusion in some of the patients, up to 57% patients. Hepatitis-like pictures leading to some coagulation disturbances, and encephalopathy, seizures, coma, or meningoencephalitis. So and everything can be seen here, really. So this disease is showing us everything that can happen. Multisystemic involvement. That's why the reason. That's the reason why the name is multisystem involvement. What are the predominant features that you have? Is abnormal cell counts, lymphocytopenia, neutrophilia. then there would be some anemia and thrombocytopenia. Remember, this can confuse you, this thrombocytopenia, to begin with dengue for us. So many patients who would come like dengue-like syndrome, you need to rule out dengue first, and then you can talk about these. In elevated inflammatory markers, so CRP definitely raised, ESR, D-dimers, fibrinogen, abnormal fibrinogen, ferritin, procal levels, interleukin-6 level, these are all inflammatory markers. This could be abnormal. Looking at chest radiograph, mostly normal. You would probably not find unless some pleural effusion. CT of probably you don't want to do it routinely, but some of the patients who are confusing you need to rule out any particularly COVID-19 acute infections. You want to do CT chest, it's fine in doubt as a part of the another important thing is abdominal imaging. Ultrasound, abdominal ultrasound or CT is very important to rule out actually any sort of appendicitis like pictures, and because you may get confused with that, as the appendicitis has got very similar presentation: fever, rashes, pain in abdomen, vomiting, and child has significant abdominal pain and tenderness. So they can also be overlapping these. Another important thing that you need to have in these patients, definitely must do an echo on admission. So there is depressed LV function in nearly 30 to 40% milder cases, and nearly 60% cases will show depressed LV function. Systolic function does improve at some point, but the diastolic function persists, dysfunction persists longer. The left ventricular ejection fraction gets affected in nearly half patients, less than 55%. And usually with these patients, when they get go to around 7 to 10 days, they will have worse cardiac dysfunction. So it is a good idea that when you see a patient, you do a first echo, 2D echo on admission. It's good to do one at around 7 days of illness. I think somebody is playing with the PPT. Sorry. Coronary artery abnormalities can be seen in 18 to 19% cases, 20 to 50% severe cases. And you could get some dilatation or aneurysm. The CA dilatation at admission were 15% in this study. And this is an Italian study, 15%, and it developed after admission in 40%. So they can develop coronary artery abnormalities after admission too, as the disease starts becoming worse. So it is good idea again, making sure that you don't miss them. You do another echo by around day 7, day 10. There could be some mitral valve regurgitation, pericardial effusion as a part of the whole disease progression. Diagnostic criteria, let's go back to that. Let's have some comparison. The CDC definition and WHO definition. CDC has 4 criteria. It says age less than 21 years and all of the following, such as fever more than 38 for more than 24 hours, laboratory evidence of inflammation related CRP, multisystem involvement more than 2, severe illness requiring hospitalization, no alternative plausible diagnosis, very important, evidence of recent or current SARS infection or exposure. So it does not need to be positive for PCR, but there could be antibodies positive or there could be an history of exposure, any of them. WHO says there are 6 criteria, against sort of similar thing. Age less than 20 years, fever more than 3 days. They have gone with the fever criteria for more than 3 days persistent. Signs of multisystem involvement, at least 2, like rash, conjunctivitis, so KD-like disease, hypertension and shock, coagulopathy, acute GI symptoms are predominantly there. So 2 of them should be there. Then you should have elevated markers of inflammation, like of course CRP, no other obvious cause of inflammation, very important, coming to diagnosis, and then evidence of recent or current infection or exposure. The diagnosis criteria and definitions are very clear cut, remember. Now this picture has come from again another European and UK study, which they tried to find out that how different the clinical presentations could be. And they felt that, okay, let's see, can they be put into different groups. So now they found that there are 3 different patterns of this disease. Group 1 will have persistent fever, elevated levels of inflammatory markers, but without features of KD, shock, or organ failure. Second group will be which will have fulfilled the diagnostic criteria for KD, so KD-like group. And third will come like in shock and in clinical echocardic laboratory evidence of myocardial injury. So clear-cut 3 things. So febrile inflammatory state, KD-like illness, and severe misc. So we have 3 different patterns of which are recognizable at this moment, and they may help us to formulate our treatment plans accordingly. So now CDC also found out that okay, we got similar sort of things, and we got more cases now, and they had a long morbidity and mortality weekly report, which included most of the cases so far they have seen, and they found that the first group was BC without overlap with. Sorry, I think somebody is playing with the PPTs. I'm not sure. Miss C without overlap with acute COVID-19 or Kawasaki disease. That is your first. Group, which is 35%. Second group is Miss C without overlap with acute COVID or Kawasaki disease, and third is overlapping with KD. So again, here we have majority CVS in first without overlap with COVID-19 or Kawasaki. They plainly come like shock-like state, cardiac dysfunction, high CRP, ferritin, and they have positive serology with or without positive PCR. Third one was without overlap with acute COVID or Kawasaki. They have majority respiratory symptoms, cough, dyspnea, pneumonia, more of a respiratory pattern. Highest mortality in these one actually, because they are more of COVID patients, proper COVID patients rather than anything else, and mainly older patients with comorbidity. So that can be explained that probably they are behaving like android COVIDs. And the majority had positive PCR, again without seropositivity. So that tells us this is an acute insult, behaves like a proper COVID. And the other ones which was overlapping with KD, like 35% of them, similar group and similar numbers, they mainly had all the KD features like rashes, infectedness, involvement. And again, of course, why it is more with KD is younger kids and less shock and myocardial dysfunction. They had positive serology, 2/3, majority of them are positive serology and negative PCR, and 1/3 of them were positive on both tests. So interesting actually. So in general, we need to keep the both the groups, as actually both the groups are managed to divide them into 3. So I like this one. This is more easy to remember. One comes with plain febrile inflammatory state, one comes with KD like illness, and third comes with none of the KD or other things, but comes with severe misting like shock and multi-organ involvement, mainly cardiac involvement. So there you are. But again, can there be just a classic KD and it happens to come during the corona time, and you're actually taking every classic Kawasaki disease as Miss C? So I'm really sorry. I think somebody is playing with the PPT. Somebody is putting lines on my presentation. I can't really see that.
Somebody's automation is on. That is why this is happening.
सर ते तुमच्या युजर कडूनच होते सर. सर एस्केपचं बटन प्रेस करा.
It's on. I'm not moving my mouse at all. Somebody is
Dr. Sarika म्हणून काहीतरी येते तिथं नाव.
I think I can see that name attached to that. Somebody's, I don't know what.
Dr. Sarika कोण आहे?
Okay. Let's get back to the work. So let's see what happens. So I do not really want we to get confused and miss actually Kawasaki disease rather than Miss C. I would miss the Miss C. So what are these? So Miss C mainly seen in older children and adolescents classically, and classic KD will be seen mainly in infants and younger kids. Again, Miss C is seen more in Black and Hispanic children and less in Asian. So we shouldn't be seeing so many, but nowadays we're seeing some. But classic KD will be seen in East Asian and Asian kids. Predominantly, Miss C will have GI symptoms, while classic KD will have more of a mucocutaneous involvement, rashes, joints, and lymphadenopathy. Myocardial dysfunction and shock will be extremely predominant, and in fact could be a presentation of Miss C, the children coming in shock, as compared to classic KD will not have it, but sometimes you can see that KDSS, which is Kawasaki diseases like shock-like syndrome, can present with myocardial dysfunction. So that is one confusing thing again, but you need to make sure the other parameters are important. There would be marked lymphopenia and thrombocytopenia with Miss C, while classic KD will rather have thrombocytosis, mildly raised inflammatory markers. And coronary artery involvement is unclear in both of them. Obviously, one of the criteria for diagnosis of KD could be coronary artery involvement, but Miss C may or may not have it. And very importantly, the association with SARS-CoV in any possible format, either in seropositivity, PCR, or the exposure would be present with MIS-C, which may not have with classic KD. So that is another way of looking at these two. Is there anything else so important? Yes. Don't jump to MIS-C all the time. Although it is being seen in many centers, we have seen one or two. Probably we have seen 3 now so far. But it is so important that you rule out everything else before jumping on to treat them, because you're going to use a lot of steroids, you're going to use a lot of IVIGs, which is expensive on its own. At the same time, steroids could be harmful to these kids. So be careful before you jump. So what are the things? Most of the sepsis could look like this. Many of the sepsis will have fever, will have rashes, will have coagulopathy, will have high D-dimers. They can have ventricular dysfunction, shock, everything else. So everything else described can come with bacterial sepsis. So make sure you take blood cultures. Make sure you have taken blood cultures and started these kids on antibiotics. That is one thing. So bacterial sepsis is very important. Rule out the source of infection. Of course, you rule out Kawasaki disease, as we just spoke now. What was the difference between these two? Toxic shock syndrome, staphylococcal, streptococcal toxic shock syndrome, they share many similarities with MIS-C. So another important thing, you do your SARS-CoV testing and the serology, at the same time take bacterial cultures. They are necessary again to make a distinction between the two. Appendicitis is very common. You shouldn't be missing appendicitis. In fact, one of our patients actually got admitted for appendicitis because the initial ultrasound which was done outside was suggestive of there is a swelling of intestinal linings of appendicitis. So he actually came and had a surgical reference, and then turned out to be COVID and antibody positive later on. So MIS-C can mimic the presentation of acute appendicitis very well. So abdominal imaging is extremely important in this situation. Viral infection like EBV, cytomegalo, adeno and enterovirus, they can have myocardial involvement, and they can have viral myocarditis, and they will come with shock as well. But remember, these cases are not commonly seen in healthy kids. They are usually seen in all the immunocompromised patients. So at this time, it is important to do serology and PCR for them as well. And HLH and MAS, that is the macrophage activation syndrome. These two are again overlapping with MIS-C as well. So you need to be careful about these. The syndromes of excessive immune activation that can occur in previously healthy children, very same as per the MIS as well, often triggered by an infection. And in these children with underlying rheumatological condition. Some of these kids will have underlying rheumatological conditions. So cardiac and gastrointestinal involvement are less common if they are HLH or macrophage activation syndrome. They will have different way of presentation, maybe more of neurology rather than cardiac and gastrointestinal involvement. Systemic SLE, again SLE can present with fulminant multisystemic illness. These kids have generally considerable renal involvement and neurological involvement, which is not the prominent presentation with MIS-C. Vasculitis other than KD can present with fever, rash and elevated inflammatory markers. So this also can be part of the illness, but you need to rule that out. And tropical infection, of course, dengue for us is very important. Scrub typhus, rickettsia, and specific serology needs to be done to rule out these diagnoses. So it is important. So why I'm stressing on this is not everything that you see nowadays with shock and sepsis and rashes is MIS-C. You keep that in your mind, but rule out everything else. That's very important. Management, actually you need to send all the investigations to come to diagnosis, particularly for ruling out other differential diagnosis. Hemogram, inflammatory markers, LFTs, that is your part of the routine coagulation profile. Cardiac evaluation is very important. You must have a 2D echo done at the point of admission, definitely, and one more, at probably around 7 days time. And you need to send the enzymes, cardiac enzymes, to know actually whether you are moving into cardiac failure, left ventricular dysfunction. Then serology for other viral illnesses such as dengue and others should be done. Blood culture should be taken. Chest X-rays, yeah, okay, you want to rule out anything like pleural effusion to deal with the hypoxia and other things. Yes, abdominal sonography and CT scan is important for chest and abdomen. COVID PCR serology needs to be done as a part of ruling out MIS-C. How do you treat them? There is a specific treatment, so, and how relevant they are. So importantly, what you need to deal with is first is treat the shock. So you would get patients who would come to you many times in shock-like state. So treat the shock, give them fluid boluses and reassess. If no improvement, you can consider inotropic support. Don't keep on giving them boluses of fluids unless you think that it is not missing. So the treatment needs to be evaluation at the time of boluses, and then if you don't have any improvement, if you have facilities, start with at least peripheral inotropes and to deal with that rather than giving lots of boluses, because this could be missed then. If you want to start on something, and then your first call could be noradrenaline, because most of them come with warm shock-like state. You can even add vasopressin to improve blood pressure. Adrenaline infusion, if there is significant LV dysfunction, you have had your 2D echo and you found that the LV dysfunction is significant, you can add adrenaline. Milry infusion is added after echocardiography and ECG, which suggests myocardial dysfunction. So you have these ways to deal with the shock. So deal with the shock first. Then you think about immunomodulation. Now, patients under investigation for MIS-C without life-threatening manifestation should undergo diagnostic evaluation, as well as other possible infectious things. As I said to you again, few patients with mild symptoms will not have any multisystemic involvement and may not need anything doing. You just need to monitor them closely. You don't need to jump to treat them. They may not have anything. IVIG is your first call. IVIG high dose should be considered. You can give 2 gram per kg over 24 hours or 48 hours. Importantly, very important, the IVIG has got a high fluid volume. So make sure that you have that under your control, that your child is not having fluid overload and you are controlling the blood pressure effectively and his cardiac status is good. So you need to assess the cardiac status, because this could lead to sudden fluid overload and in fact you would harm rather than help. Now, this is very good guidance actually. So American College of Rheumatology has given a clinical guidance for pediatric patients with MIS-C. Now what they said is you can start with methylprednisolone. When child is in refractory shock, needing inotropes and fluid boluses and is not responding to IVIG, your next call is methylprednisolone. So high-risk children are those who are younger than 12 months and those with CA abnormalities. So you shouldn't wait for them and go on with the methylprednisolone. The good one they say is to start with pulse methylprednisolone, high dose 10 to 30 milligram per kg per day for 3 days, followed by slow tapering into oral prednisolone 1 to 2 milligram per kg per day over 2 to 3 weeks. A prolonged weaning with steroid is warranted after the pulse methylprednisolone. And if you do not have response with this, then you have other biological agents, anakinra and tocilizumab. So of course, here comes the role of tocilizumab so far in COVID in pediatric patients. And a lot of centers have used tocilizumab, particularly for MIS-C and PIMS in Europe as well as in US. Now, antiplatelet and anticoagulation therapy. Now here you can start on low dose aspirin. 3 milligram per kg should be used in patients with MIS-C and KD when you have significant thrombocytosis as well. So aspirin can be started in that. If your child is still quite high febrile and you can treat them as a KD, classical KD shows the complete KD disease definition. You can consider giving even higher doses to begin with, as you do in Kawasaki's disease. But nowadays, this is advisable to go with the low dose aspirin, 3 to 5 milligram per kg per day. It can be continued until the normalization of platelet count and confirmed you have a normal coronary if they are involved. So usually I would say 4 to 6 weeks after the diagnosis is what you would want to taper them off. It should be avoided in patients who have platelet count less than 80. I would be very careful with that. MIS-C patients with coronary artery abnormalities and a maximum Z score of 2.5 should be treated with low dose aspirin. Remember, you ask the Z score to your cardiologist, and if you have a Z score which is above 5, above 2 but less than 10, then you can use low dose aspirin alone. And then if you have a patient who has Z score more than 10, they should be treated with low dose aspirin and therapeutic anticoagulation with enoxaparin. And you can keep the factor 10A level between 0.5 to 1, or even use of warfarin has been documented. And this is from the Rheumatological Association of American Association. And if you have any documented thrombosis or the ejection fraction less than 35, they should receive enoxaparin for longer duration, in fact, up to 2 weeks after discharge as well. So enoxaparin dose, therapeutic as well as prophylactic. Prophylactic dose is up to 0.5 to 1, and therapeutic is from 1 to 2 or even 1 to 1.5 milligram per kg. OD or BD, depending upon Z score. Remember, you need to know your Z score, don't overdo that. Antiviral antibiotic therapy. Now, children with the PIMS who are SARS positive or RT-PCR, they should be considered for antiviral therapy in the initial phases if at all needed to be. I don't see that is a case in general unless they have a respiratory involvement. So if at all you have to, people have documented that remdesivir can be used. Again, the evidence for use of remdesivir, as we spoke in our first lecture in pediatric population, and the utility and the safety and efficacy is doubtful. So I would probably not venture into that. IV antibiotics should be commenced in all patients. That is most important thing that you can do to avoid secondary infections, or if at all there is a sepsis, that you can keep your patient safe. And as per the clinical picture and the blood cultures, you can stop the antibiotics as early as possible, 48 hours or 5 days. Children who meet the criteria for toxic shock syndrome should be given clindamycin in addition to broad spectrum antibiotics like ceftriaxone. So if you have suspicion of toxic shock syndrome, you can add clindamycin along with ceftriaxone. So more of a broad spectrum antibiotics to begin with. It is not necessary that your initial infection screen, you need to wait for that and then you can decide. You can start your treatment, but make sure that you send all the necessary investigation to rule out the underlying dosage and underlying infection. So if you suspect that this has to be COVID or this has to be, then you can start on steroids or antiplatelet or anticoagulation therapy as per the guidelines, as I said to you before. Interesting one, the International Kawasaki Disease Registry has gone ahead and actually took a survey of these centers, a lot of centers across America and even Europe, and asked them that what was their use and what was their preference of usage for aspirin, anticoagulation. Do they think IVIG or steroid is better, whichever, or how did they use it? So let's go to the first one here. I want to start with the initial treatment, IVIG or steroids. If you see, all of them had a preference of, if you take overall, the preference was IVIG to begin with. If patients had myocardial involvement, if they divided them, then there is an equivocal. So you can use steroids as well as IVIG, and they get as a first-line treatment. Kawasaki-like disease features, you can use IVIG as your first priority. Coronary artery aneurysm, definitely you want to use IVIG first. But now look at here, when the child goes into a refractory state with significant amount of shock and severe clinical presentation, the number of usage of steroids goes up. And of course, for patients who are IVIG non-responders, these steroids are helpful. So overall, I would say IVIG is preferable. Now let us go to your anticoagulation use. So anticoagulation use, prophylactic and therapeutic. So prophylactic is what you want to use. Overall, prophylactic is better. Higher baseline risk for venous thromboembolism, of course you want to use just for baseline risk, you want to use that. Severe clinical presentation, you want to use therapeutic doses. Elevated D-dimers, actually equivocal. Any ventricular dysfunction, use more of a low dose. If you have at least moderate ventricular dysfunction, you can go for therapeutic one. So far and so forth, I would say the preference is given to the prophylactic dose. Same for our patients as well, we should use. Aspirin, anti-inflammatory, antiplatelet, same. Overall, this antiplatelet dose is what people have used. Kawasaki disease features is same. Some of them have used anti-inflammatory. Coronary artery, again, more of an anti-inflammatory dose given first. Ventricular dysfunction, more of antiplatelet dose there. Severe clinical presentation, again, anti-inflammatory. So it is interesting, this paper, that it goes into the insight of how people are treating MIS-C. Now, we can have our Indian guidelines. We have recently come through. How would we want to treat them? Taking into consideration of all of them. COVID-19 associated febrile inflammatory state, as we said, there are 3 groups, and they also have got out into 3 groups here. You may not need to treat these patients. These ones who have Kawasaki-like illness, if you have no shock or no coronary agitation, IVIG, aspirin high dose, they have mentioned here, maximum 4 gram, decreased dose to 3.5 after resolution of fever for 48 hours. Okay, so these are Kawasaki-like diseases. With shock, multisystem involvement, coronary abnormality, IVIG, then pulse methylprednisolone and aspirin low dose. And if it is anticoagulation, then Z score has to be more than 10. Then toxic shock-like syndrome, classic multisystem hyperinflammatory syndrome in children, properly diagnosed with that. Comes with the shock, you start with vasopressin shock, you give fluid boluses. If it is fluid refractory, start vasopressors early. Either you can give diluted peripheral or insert the central line. IVIG is first line plus minus methylprednisolone, high dose pulse methyl followed by low molecular weight heparin. If there are signs of LV dysfunction, which is around 50% of patients, you will have narrow pulse pressure, vasoconstriction, echo evidence, and troponin, which are high. Then you can start on adrenaline. Maybe dobutamine and milrinone has a role here. Early NIV or high flow support. I would not go with NIV. I would go with HFNC if needed. I will intubate. Give IVIG here, methylprednisolone, and low molecular weight, so that the last you can think about that. And of course, these are steroid-resistant diseases. You can think about anakinra, tocilizumab, infliximab. Again, not a very strong evidence for that, but yes, in desperate situations, you can do that. So basically, what is it? There is variation in the management of PIMS TR across the various centers that you see. So some of them come with shock, ventricular dysfunction, gets treated with IVIG as a top, steroids, tocilizumab, and maybe anakinra, infliximab here, not very top of the list here. Kawasaki-like disease can be presented. Then you can use the similar thing here, IVIG, steroids, tocilizumab. And if there is fever with inflammation, you may not need to treat them. If they are, if at all anything, then you have inotropic support, mechanical support for any of these patients. Many of them will require some anticoagulation, but make sure not all and not everyone. And then there is not good enough evidence to assess that one treatment is better than the other. But obviously, you need to take the decision as per the cases that you see, and either don't overgenerously treat with lots of anticoagulation, and it has got its own problems. And I would definitely request, we'll come to the take-home messages here. So although it is it is now seen across everywhere, it's not something that every pediatric cohort is PIMS or it is missed. So make sure that you rule out other cases, other causes of fever, shock, and rashes in children. Cardiac evaluation is must using 2D echo, is most reliable tool to make a treatment decision on admission around 7 to 10 days and 4 weeks. IVIG is your first line, followed by methylprednisolone. Aspirin use must be tailored as per clinical assessment. I would go with the Z scores. And indiscriminate use of phenoxypyrin exam should be avoided. Make sure you have D-dimer levels, and I would even go more with Z score as per the making decision for using anticoagulation. I hope doing all these things, you just need to keep on evaluating yourself, hang on there, and then everything should be fine.
Thank you very much, sir, for your excellent presentation. Majority, probably 98% of my questions are erased now, but still there are some questions I would like to ask you.
Yeah.
We have found that 34% patients have RT-PCR positive and IVIG positive. Whether they are infective to us, and whether they should be treated in COVID ward or in the general ward.
Okay, this is always a question that you would get because I would say most of these patients would have some sort of exposure to COVID, but many of them would have passed the situation of being infective to others. But it is still better to treat them in isolation rather than mixing them with the general population. Okay.
In your experience, how many cases you have clinically diagnosed with RT-PCR negative and serology negative?
I mean,
RT-PCR negative and serology negative, and clinical suspicious of, in your experience?
Yeah, we had 3 cases so far in Dinanath, and all 3 cases were initially RT-PCR negative. None of them had RT-PCR positive. One of them we didn't test for antibodies. The 2 cases we tested for antibodies really at the end, because we sent antibodies twice, we couldn't get them. But on the second or third lot of antibodies at the time of discharge, we found them to be positive. But there was a history of exposure in one of them. The other had no exposure. He just came and was referred. As I said, he was referred for a surgical. Actually, he was referred for acute appendicitis.
Okay. Which test you are using, whether it is a quantitative titer or a spot test you are using for the antibody, or any difference between both of them?
We are just doing IgG test. So if it is IgG positive, we
with
get
the titer or with spot test?
Just a spot test. Just
spot test. Okay. Is there any difference between spot test and titer test regarding
Not,
specificity and
not
sensitivity?
to my knowledge, no.
Okay. Sir, we have seen that responding to the IVIGG, how time we should wait for the response to come, not to give
Uh,
on methylprednisolone.
I would say
Hmm.
if you suspect early and you want to start on IVIG, if you think that this child has BC and you rule out everything else, IVIG needs to be given at the earliest, first line, as
Yes.
we said.
Yes.
If you think that the child also had associated shock and is not actually responding to the IVIG, the fever is not coming down, and the child still had persistent shock-like presentation, you would want to add methylprednisolone.
Okay, after 20, suppose a patient with shock, they recommended IVIGG plus methylprednisolone simultaneously. I don't know, because if severe
Um,
LV dysfunction is there, I
yeah.
don't know whether it is right or wrong.
It is again, doing repeated echos and find out there is a significant amount of LV dysfunction. What are the platelets? How is the underlying infection? You can think about that, adding steroids. But if you have persistent LV dysfunction, you have fever, and you have already given IVIG on day of arrival, and you have suspected that, and your child is still not showing the signs of improvement within 24 to 48 hours,
Okay.
you are justified to add on methylprednisolone. That's not a problem.
Okay. In how many patients you need to use the tocilizumab in your scenario? None. Okay. The one question is how you know the non-responding to the IVIG and methylprednisolone? How the same question? How time we should wait?
Okay. See, methylprednisolone has a 3-day course. If you give pulse methylpred, so definitely you would want to start on IVIG. Then you have suspicion, you are worried, you have LV dysfunction, you want to add methylprednisolone. You definitely add methylprednisolone, start on a pulse methylpred. That goes on for 3 days.
Okay.
Most of the cases will resolve at the end of 4th day or 5th day by completing the 3rd dose of methylprednisolone. So, having seen that, we haven't seen enough patients to say that there are non-responder to IVIG and methylprednisolone. These are the cases which have come from Europe and American data, and they have talked about when you don't have nothing worse, then you add Ankendra and remdesivir and tocilizumab. But the first case that in India we had in Kachi, Komakoti, Tamil Nadu hospital, Dr. Balasubramanian treated that, and that patient actually was treated with IVIG, was treated with methylprednisolone, antibiotics, aspirin, but he continued to have persistent fever. And although he was shifted outside into the ward, he continued to have fever, and he could not relent. And he was getting worse with his fever. He was going into sort of warm shock. So that's why they had to resort for tocilizumab in that case. So as a routine, I wouldn't say that you would see these cases very often, but most of the times you finish your 3rd dose of methylprednisolone, pulse methylprednisolone, by 4th day, you should be seeing changes.
Okay. In some literature, they say each and every patient of MSC should get the aspirin for the 14 days, not depending on the platelet count. What is your experience or what is your thought?
Yeah, I would suggest aspirin is worth giving to these patients, because these patients are at risk of developing complications later, although they may not show you the cardiac or coronary artery involvement. But if they have coronary artery involvement, definitely you want to give them aspirin. But even otherwise, you would want to put them on aspirin as well if you have cardiac involvement particularly.
Okay, sir. We have so much of inflammatory markers, probably 5 or 6. What is your point, which is the most sensitive and will change our line of management out of all this?
None of the markers on their own will change anything. Okay. It has to be a collective collective data that you get. So you must have, or you should have, a higher levels of IL-6, D dimers. You should have high ferritin CRP. These are the important ones that you would normally want to see. All of them are moderately elevated. If you just have one of them moderately or highly elevated, but your clinical suspicion picture is very, very, very classic and clear, then you may go ahead with even that one of those. But if you don't have a clinical picture, you don't have any suspicion, and you just have one marker, high, say D dimers. So most of the times, high, really just one D dimer high, how many times tell me how many times in pediatric septicemia or septic patients we used to do D-dimers? No, we don't do that normally in pediatric population. It's only in COVID that people have started to see, okay, D-dimers, and now the D-dimers are, but anyway, in other septic infections or other illnesses also, D-dimers could be high. We don't assess their coagulation function because now it is coming in the COVID era that people are being more sensitive to D-dimers. So I would say there has to be a collective rise of inflammatory markers to make a decision, and your clinical suspicion. It has to be a very strong clinical suspicion, a correlation with both of them.
Okay. One is in the initial period of dengue and MIS-C. How can you differentiate between, because the high grade fever, toxic, pain in abdomen, vomiting, only how you can differentiate between both of them?
Yeah, I mean, see, in one of my slides, I said, there is thrombocytopenia that in early phases that you will get thrombocytopenia with severe MIS, and that can exactly mimic like dengue. So many times it happens that then but the dengue has what will be your important thing is again your clinical assessment. The dengue will have a proper way of improvement in platelet counts without having to do anything. One. Secondly, you can always send more than one investigation. So you can always do one antigen depending upon the time of presentation, fever, and then you can send antibodies for dengue very well. You can send twice or thrice if you need to. For one of our patients, we send twice antibodies for dengue because the referring pediatrician was very sure that this was dengue and he has some abdominal complication. So we had to rule out that, and we did it twice. So it can be done twice.
CRP in dengue, majority time CRP is negative in
Negative,
dengue.
yeah. And then you would have CRP very high with MIS-C.
And the second thing, LDH and ferritin will be high in dengue also. So that should not be.
It is very overlapping.
Overlapping. Okay. Few questions in you.
I hope we have covered, I think, most of the.
Probably all patients are from the COVID only. For the COVID patients, both have Klebsiella hypoxia steroids. Probably we have covered all these things. If anybody had a question, they can directly ask by unmuting yourself.
I request participant to fill the feedback form before leaving the Zoom meeting.
Prasanna sir, I want to say thank you for the excellent presentation, sir. And majority, I thought 100% of my own questions has been resolved. And thank you very much. Thank you.
Thank you. Thank you, Dinanath Mangeshkar team, Dr. Rajan sir, Dr. Shilpa ma'am, and very well known Dr. Sumant Patil sir, and one of our best presenter, Dr. Pandya sir from the Gujarat. He has given us timing. Thank you very much. Thank you, Shishir sir, for giving me opportunity to moderate this session. Thank you, everyone.